Welcome to the Real GI Doc Show. I'm your host, Dr. Fred Gandolfo, and I'm a board-certified gastroenterologist with a practice in New York. Today's episode, we're going to be covering a whole bunch of questions that listeners have asked, and I must admit that I've been delinquent in answering these questions. They have been piling up, and I've been working on other episodes, and I just have put these to the side. So today, we're going to bang out a whole bunch of these questions in rapid-fire sequence because they're not super complicated questions, and I think the best way to do it is just to go through them. So I'll play each question, and then I'll answer it. And you should stick around to the end because I have a kind of like a rant that I've been sitting on for a little while, and I almost did this episode when I was all fired up about this, but I would have probably got an explicit rating. So I'm going to give you the rant at the end because it's something that's more generally interesting to people. It's about insurance and drug companies and all this crap that just drives me crazy when I'm trying to practice medicine. Anyway, let's get into the Q&A, and I should also give you the disclaimer that this is not really medical advice. I am giving this information really for entertainment purposes, and if you have questions that are similar to this, the best thing to do is to ask your doctor, not the guy on the podcast, unless this guy is your doctor, and then you have to ask me in the office, not on the interwebs. But these questions hopefully will be generally applicable to people and they can learn a little bit about GI. So here you go. Question number 1.
I'm 62 years old. I reside in Huntington Station. I was wondering if instead of having a colonoscopy or an endoscopy, is it better just to do the capsuloscopy? Since the small intestine cannot be seen in the endo and the colonoscopy. Thank you.
All right, so that question was about should you just do a capsule endoscopy instead of doing an endoscopy or a colonoscopy? And just to familiarize people, a capsule endoscopy is when you swallow this little pill camera. It basically is like the one I use actually has 4 tiny cameras inside of it, like 4 little iPhone cameras, and they are focused really super duper close up, and there's a little light source in there that blinks, so it's like swallowing a tiny video camera inside of a plastic pill. It has a battery in it, and it basically records the images to the capsule. And this model of capsule endoscopy, you actually have to pass it and retrieve it, so that's fun, but not that hard. You don't actually have to touch anything disgusting, but basically have to bring the capsule back into us, and I'll look at the pictures. I'll download them on the computer and basically look at them like a movie. And it takes like tens of thousands of pictures as it travels through the small intestine. And the purpose of this thing is that we use it to look for small intestine bleeding, small intestine tumors, ulcers, evidence of Crohn's disease, all kinds of stuff that can affect the small bowel, the part between the stomach and the colon. So we normally can't see much on regular endoscopy or colonoscopy of the small intestine. We can see the top part of the small intestine called the duodenum or the duodenum, however you want to say it, and we can see the bottom part of the small intestine called the ileum or the terminal ileum when we do a colonoscopy, but the vast majority of the small intestine you can't really see without doing a capsule endoscopy or some other advanced technique like a special MRI or CAT scan. But out of all of those, to see the fine detail of like the mucosa, which is like the lining of the small intestine, you really have to do the capsule endoscopy test. And why don't we just do this on everybody? It would be pretty cool, right? It'd be pretty easy. You don't have to do any colonoscopy prep. You don't have to go under anesthesia and whatnot. But the bottom line is that the capsule test doesn't really look at anything but the small intestine. It doesn't really get a great view of the stomach. It doesn't really get much of a view at all of the colon. And there's different reasons for this. Mainly the small intestine is pretty empty if you're fasting. And the capsule is just the right size that it kind of takes up a lot of space in the small intestine, and the camera can kind of see the walls of the small intestine. Because on the upper endoscopy and the colonoscopy, for the upper, you have to be fasting, of course, but also we blow a lot of air inside your stomach to stretch out the wall so we can see what we're doing. Otherwise, the stomach would be kind of collapsed, and you wouldn't really be able to see much fine detail in the wall of the stomach. So that the capsule test, you can't really blow air in there, so you can't really see much. And it's just too big of a space for that light to really light up. It's like trying to light up a cave with like a little tiny flashlight. It's not going to work. Where the small intestine is much smaller, and the light source on the capsule does a really good job at lighting it up, and you can see everything. And as it passes through, you get a lot of good detail. And when it gets to the colon, all you do is really see a lot of stool. And if you did a bowel prep, first of all, you have to do the bowel prep, which would not be fun. But if you're using a capsule to look at the colon, you'd have to do a bowel prep. And also, the colon, again, is like not stretched out. Usually when we do always when we do a colonoscopy, we inflate the colon with either air or carbon dioxide. It's called insufflation. And I use carbon dioxide, and most people use carbon dioxide now, I hope, but it basically stretches out the colon so you can see the details of the lining of the colon. Otherwise, it's all scrunched up and you can't really see inside of it. And without doing that, you can't find polyps and you can't really see anything. So the capsule doesn't work in the colon at all for that reason. And plus, with like lots of people having polyps and other things, you can't really intervene with the capsule. So if we see a bunch of polyps in the colon, say we could stretch the colon out with the capsule and see the pictures, what do we do with those images? It's great. Hey, you got 5 polyps. Now we have to bring you back for a colonoscopy. So not the best use of expensive technology. But if you have small bowel bleeding or some other issue, or you're iron deficient anemic, or you have some concern for Crohn's disease or whatnot, then the capsule test is a great alternative and a great test to do. So we do a lot of them, but definitely not as a replacement for a colonoscopy. All right, on to the next question.
I just want to urge you, when I consult with you, that you do over-explain and make me the exception. I love your explanations, and it makes me understand my situation, which on my own I would not be able to without your assistance. So that's one of your 9 issues that I would take exception to. For me, not for everybody. My eyes will never glaze over when you talk. I listen to you. Thank you for your podcast, and thank you for your care for patients.
Okay, well, that was a nice message from Diane, and basically she's referring to episode 33, which was like my New Year's episode, and I talked about how I want to stop over-explaining everything because I waste a lot of time saying the same thing to people 8 or 9 times and over-explaining it from 5 different angles. But some people like that, I guess, and I assuming that people do enjoy that, or maybe it just makes more sense when people hear things a few times. But I still stick to the not over-explaining stuff as much as I can. And I notice that I'm like in the exam room when I'm talking to patients, I'm like, oh, I'm going to do it. I'm going to over-explain. And then I pull myself back a little bit, but I probably still over-explain more than the average person. But that's just me. And what are you going to do about that? Nothing. That's just the way it is. And Diane likes it, so I'm going to keep doing it a little bit at least. So thank you for the compliment, I guess I'll say there. That's a nice message. All right, let's get to the next one.
Hi, Dr. Fred. This is Christine in Amityville. I'm calling about a problem my husband has been having recently where he feels that he can't swallow. He has trouble swallowing. Occasionally, he feels like food is getting stuck in his esophagus, and he tries to cough it up. A recent exam by the doctor showed that he has a twisty esophagus, but there was no explanation as to why or how this happens. And we're waiting now 2 weeks for biopsies that we're taking during an endoscopy. My question is, what is a twisty esophagus? What can be done about it? And is this a dangerous situation where we have to worry about him choking?
Okay, so that question was about a twisty esophagus from Christine. And this is a more complicated situation. So I'll give you my thoughts off the cuff because I don't really have the clinical details with me. So when someone has trouble eating or food's getting stuck, we call that dysphagia. I mean, you can't really swallow normally. It's a swallowing problem. People come in for this all the time. And you have to make a differentiation. Is food getting stuck like you feel it going down, but it's not really going down normally, or it feels like it gets stuck but eventually passes through? Or does it really get stuck like you can't swallow certain things? And if you try to eat, for example, a piece of steak or something like that, it gets stuck and it comes back out on you. Like you actually have to regurgitate it because it physically won't pass. This sounds more like, Christine's issue sounds more like the food is just getting stuck like it's going down slowly, but it still passes through. So in that situation, you start thinking of what's called motility disorders, like reasons like the esophagus is not pushing the food down properly, or maybe there's some problem with the muscles in the esophagus and things are going down slowly. And you can also get the symptoms with just acid reflux issues and other problems that cause inflammation of the esophagus and a whole host of other things. But when food's getting stuck and it's going down, I usually think more of like a motility problem, and it deserves further workup. And it sounds like her husband had some tests done, at least an endoscopy, and she alluded to this twisty esophagus thing. Like maybe he had a test called the barium esophagram, I'm not sure, where you would drink some barium, which is like a liquidy contrast material, and you take a bunch of x-rays as it goes down, and you watch it going down the esophagus, and you can see how the motility or the movement of the esophagus works, and you can see if the esophagus is kind of twisty. You get almost like an x-ray of the esophagus, well, exactly like an x-ray of the esophagus while you're swallowing. Maybe he had a barium esophagram, and that's what they saw. But either way, he ended up having an endoscopy to look down there, and they took some biopsies. So I'm not sure what they saw, but they told her that he has a twisty esophagus. And this is a relatively common thing that you hear about when people get older. And we call it presbyesophagus, which means old esophagus. So this is a term that has been thrown around a lot, basically. And you see it all the time when you do a lot of endoscopies, and you start doing endoscopies on people who are getting older. You don't have to be ancient. You can be, 70 or something like that and have a presbyesophagus. But you often see it in people who are 90, 80s, 90s and above. And it's often when the esophagus just kind of looks stretched out and twisted, for lack of a better term. And this used to just be a diagnosis. People would just say, oh, it's presbyesophagus. What are you going to do? So, people are getting older. Just like you get wrinkles on your skin and you can't run, a 4-minute mile, your esophagus also slows down as you get older. And it's probably partially true. Connective tissues loosen up, muscle tension goes down, nerves degenerate as you get older, and stuff just slows down. Why is that the way it is? It's just the way it is. But more recently, I think people have started to study people with just this presbyesophagus diagnosis and done more formal testing and found that there's actually, a lot of times it's not really just aging, there's actually stuff that's going on in the esophagus. So these things are called motility disorders, and people can develop motility disorders that you find when you do a study. And some of these things have treatments that are available, either medications or mini procedures that are done, and at least you get an answer there. So really, a motility disorder is best diagnosed by someone who specializes in esophageal motility. This is a section or a subspecialty of GI. So not every gastroenterologist does motility testing. I do not do it, and most people don't do it. But most university centers or other places will have motility experts or esophagologists, as they call themselves. And the testing they can do, there's a whole bunch of tests out there that they can do, but the classic one is just called esophageal manometry. You're awake, they stick a little tube up your nose and you swallow it. It's not the most comfortable thing in the world, but it goes down into the stomach, and they have you swallow a few times, and they can measure the pressures and see actually what's happening in the esophagus when you're swallowing in real time. And they'll give you some information like what exactly is happening when you swallow. What are the muscles doing? Are the muscles weak? Are they overreactive? Are they hypercontractile and they're squeezing hard? Are they spasming? There's a whole bunch of different motility disorders that you can diagnose by doing a manometry test if you wanted to get more into it and find out exactly what it is. And there's also more advanced techniques and things that they can do, but that's the basic one. And basically what you do is you just ask your gastro doctor, like, does this require referral to a motility specialist in the esophagus? And oftentimes there's no real harm in getting some further information. It's a little bit uncomfortable. But when this is the situation and there's no answer, then that's kind of the thing to do. But to answer the second part of the question, typically this kind of thing is not dangerous. There are motility issues that could be dangerous because you could choke on food and have problems. But this sounds like it's probably not one of those things. But again, without much more information, it's very hard to say for sure. That's really it. The old twisty esophagus. Got to be careful with that one. All right, let's go on to the next question.
Hi, Dr. Gandolfo. I just wanted to know if you think taking Preservision is a good idea with chronic pancreatitis. I have macular degeneration and I should be taking them, but I'm just not sure if it is safe for my pancreas. They do make me nauseous. They always did. But anyway, I wondered if you felt that they were safe. That would be Preservision for my macular degeneration problem. Thank you. Bye.
Okay, so that's a question about the supplement Preservision, which is for macular degeneration. And a lot of people come in on these supplements that are basically like vitamins and antioxidants they take for vision, to I guess, preserve their vision. Preservision, pretty cool. So the question was, if someone has chronic pancreatitis, like this patient does have, should she take this stuff? Is it safe? And I had to look this up because I don't really know what's in Preservision. I know it's a bunch of vitamins. And it's lutein, vitamin C, vitamin E, zinc, copper, and something called zeaxanthin or something like that, ZEA xanthin. It's supposed to be an antioxidant substance. And as far as I know, that stuff is safe for the pancreas. I think in regular doses, I don't think I'd particularly worry about this with the pancreas. I mean, there are lots of things that can cause issues with the pancreas, but none of these things on the list jump out at me as stuff that I would worry about. So I would just try it and see, if it's helping your vision, or if your doctor thinks it actually does help with preserving your vision. Macular degeneration is not really anything to mess around with either. Your eyesight is crucial to maintain as you get older. And if your pancreas is okay and there's no further damage being done or whatever it is, then I don't see a reason why you should not take the stuff. And that's it. So yeah, it should be safe for chronic pancreatitis as far as I know. But obviously, got to ask your doctor. All right, so let's hit up the next question.
Hi, Dr. Gandolfo. My name is Anita. I'm a 58-year-old female from Long Island. Just listened to your podcast on anti-inflammatory eating. It was wonderful, pretty much what I've been following for years. Last year, I found out that I have SIBO. I don't understand what caused it, but I've had to make some modifications through a low FODMAP diet, and I've been reintroducing reactive foods. Most have been successful, but beans, legumes, and cruciferous veggies have been challenging, and I'm concerned about missing the nutrients and the benefits from those foods. I'd like to hear a more concentrated podcast on this condition and in the way that you highlighted diverticular disease. So hopefully you'll find a way to fit that in. Thank you again for all you're doing, and have a wonderful day.
Okay, so that was a question that was referencing one of our episodes. It was episode 18, where I spoke to dietitian Stephanie Schiff, and we talked all about the diet that you would do for basically for diverticulitis, but also for many other inflammatory conditions and cancer prevention and general aging. And it's an antioxidant-rich, anti-inflammatory Mediterranean-style diet, and that was a great episode because we got to talk a lot about that and how simple it is to do and how many health benefits there are there. So Anita was asking about requesting a similar episode where I took a deeper dive into diet with respect to SIBO, or small intestinal bacterial overgrowth. So SIBO is an interesting thing in and of itself, and eventually I'll talk more about it, but it's basically a condition where you have just abnormal either populations or just numbers of bacteria in the small intestine where they really shouldn't be. Your small intestine is not sterile, but it should not have like a lot of bacteria in it like the colon does. And for some reason, in many different people, there's different risk factors for it, but you can have this thing called bacterial overgrowth, or SIBO, SIBO. Some people say SIBO, but I like to say SIBO because that's just what I do. And basically what happens is it causes all kinds of problems in some people. It's probably underdiagnosed and overdiagnosed at the same time. It's probably underdiagnosed in people in general, and it's probably overdiagnosed in people who have like just vague symptoms and think they have SIBO, because a lot of people come in saying they have SIBO, but they don't really have it. You could test for it. There's tests we do for it. That's not what I'm going to talk about today. But basically, she wants to talk about this diet change called the low FODMAP, FODMAP diet. And this is the diet that's been around for quite some time now for SIBO and other conditions, and it's supposed to help with bloating and other type irritable bowel issues by just reducing the amount of liquid and gas and stuff in the small intestine. And if you wanted to do it right, it's a hard thing to do, or I should say it's a thing that you need to do with guidance. You really need to do it with a dietitian. So I'd like to get a dietitian on the show again and really go through the low FODMAP diet. It's funny because this has been on my list of topics. I have a list of podcast topics that probably can keep me going for the next 2 years. It's just a ridiculous amount of things to talk about. And it's so hard to get these things going when you have a full-time practice and all that stuff. But that's on my short list of things to do, is have a dietitian on to talk about bacterial overgrowth, low FODMAP diets, and all that jazz. So hopefully in a future episode soon, I have 1 or 2 people lined up. Got to see if anyone pulls the trigger on it. But we'll see what happens. And I'll hopefully get a dietitian on, and we'll do a nice long interview about this diet and why really it's best done with a dietitian, I think, because it's a restrictive diet in the beginning, and then you slowly add things back to the diet, and it's really best done with more intense guidance rather than just doing it yourself on the internet. And God knows that I do not have enough time in the exam room to go through these kind of diet changes with patients, because they are just, it's a whole discipline in and of itself. It's like a 40-minute discussion to be had, every 2 weeks. It's just not going to happen in the regular GI world. That's just not what we do. But dietitians do that. So that's why we work together with our colleagues. And that is that one. And the last one, here's a question.
Are there any side effects of long-term use of a PPI?
That's a good one. And what's funny is I was going to do this. This has been a topic that plagues all gastroenterologists, I think, and the whole concern about PPIs, or proton pump inhibitor medications. And these are very commonly used drugs. You'll know them as drugs like Nexium or Prilosec and pantoprazole or Protonix. There's a lot of different drugs out there that are in this PPI category, and they're given for like acid reflux, GERD. They're given for all kinds of other upper GI issues, bleeding ulcers, many other things. So we basically give them a lot to patients. It's one of our top prescribed drugs. And there's been all kinds of studies of loose quality showing that these drugs may have all these long-term side effects. And a lot of these studies are not great studies in terms of their quality is not very good, and they really cannot draw conclusions like cause and effect conclusions. However, they're reported constantly in the lay press, and most patients and many doctors warn or come in and basically say, like, I don't want to take these drugs and whatnot. So that is a really good question, and I really want to delve into it on a future episode. So you won't get the answer to that question today because it is complicated. It's complicated. There's a lot of stuff to talk about, and the bottom line is these drugs are rather safe if you need them, and that's more of the what I want to talk about in a dedicated episode. Is like, if you need them, why do you need them? Do you need them? Can you get off the drugs somehow? Is it a lifestyle thing, or do you have a condition? And then let's go through the real risks. Like, what are the real risks? Because there's tons of stuff out there in terms of data, and it's enough for an episode or even 2 episodes to talk about. So I'm going to leave that until next time. And it would be really cool if I can get an expert on here in a different field that has to do with these drugs, like a neurologist or someone who deals with patients with dementia, because that's one of the big things that came up recently. But also there's been studies back for years linking these drugs to all kinds of other conditions. And causation and correlation, they don't always, you cannot prove them from these studies. That's the problem. You can prove correlation, but you cannot prove causation for most of these studies. So it's an interesting thing to talk about. And I'll leave it at that, but you'll hear more about that soon. All right, and now that's the end of the Q&A time. That's enough for that. I should say that if you have questions, please send them in, because I'm going to try to do a lot more of these rapid-fire Q&As instead of these long, 30-minute episodes on one question. So any questions you can think of, big questions, small questions, embarrassing questions, funny questions, comments, ideas for future episodes, the best thing to do is just to go on and leave them for me on that audio link that I will post at the bottom in the show notes, but also you can find on my website. You can go to Instagram, you can go to Facebook at RealGIDoc, and is the handle, or whatever you call it, and you can find the link there. And you can also use the start page. I love the start page. It's the link to all my stuff without having to go to the actual, to actually find the clunky website that is behind the podcast. So it's RealGIDoc, RealGIDoc.start, START, .page, and that will bring you to basically a link page with all the stuff on it. You can go on Apple and Spotify and find the podcast. You can watch the episodes on YouTube using a link there. You can go to the podcast website to find the archives. You can join the newsletter, and at the very bottom, you can submit a question, and all the social links are there too. So it's the coolest thing in the world, realgidoc.start.page, and you'll find everything you need there. So please leave me a question if you have a question for me. Now, I wanted to rant a little bit because I was going to actually make a whole episode about this, and I figured it's not really enough for a whole episode. I don't really have any great conclusion here. I just wanted to yell into the ether a little bit about this. So inflammatory bowel disease, it's a condition that really can be pretty severe and can really ruin people's lives. And there's really great treatment for it out now. And it affects young people probably disproportionately. So, I see lots of young patients with inflammatory bowel diseases. And this is Crohn's disease or ulcerative colitis. Those are the two main things that we're talking about here. And the symptoms are not subtle. It's rectal bleeding, it's abdominal pain, it's anemia. People are in the hospital, they're having 10 to 15 bowel movements a day. It completely controls your life when it's flaring up, and you can't do anything. You can't function, you can't go to work, you can't have normal interactions with people, you can't exercise. Sometimes you're like totally fatigued because of the inflammation in your body and the rectal bleeding and the blood loss and the anemia. And it's not cool. And, 50 years ago, it was really terrible. You had to have surgery for this. There was only limited medications out there. And nothing was really targeted specifically to this disease. But we're living in the future, man, and there's like tons of good stuff out there for inflammatory bowel disease. And not every single patient can get remission. There are still people that have to go for surgery for extremely aggressive disease, or if the medicines are mishandled or whatever the issue is, and they run out of options. But the majority of people can be treated very successfully with drugs that are overall quite safe. And the shame is that when we have the tools, but the damn insurance companies don't let us give them to the patients in a timely fashion, or other delays in care, and bad things happen. So recently, I had two patients that kind of have parallel courses. They're both young men. They both were diagnosed with inflammatory bowel disease years ago, and they both were in remission on a drug called Entyvio. You may see it on TV, Entyvio. It is an antibody. It gets given by injection. It comes in a subcutaneous form now, so like a pen you can give yourself at home, but also the classic form, which is still great, comes in an IV infusion. And you get the IV infusion usually at your home. Someone comes to your house, like a nurse, then they give you the IV infusion. And what it does is it basically is an antibody that binds to these receptors on your colon that basically are where inflammatory cells, like white blood cells, attach and get into your colon. So if you block the binding sites of the inflammatory cells in your body that are trying to attack your colon, then the damage doesn't happen because you've kind of blocked out the invading white blood cells that think your colon is the enemy. And it's amazing. It's targeted mainly to the colon and really has a low side effect profile. And overall, it's a pretty good drug, especially for young people who really want to keep themselves on a very targeted drug regimen that just kind of works on the organ that has the problem. And this is not really a discussion about Entyvio, but it's been around for a fair amount of years now. It's got a demonstrated safety track record, and it's been around long enough that it should be in some way affordable. It just seems absurd. So these patients, both on Entyvio, both were started by myself, maybe, I don't know, one was probably 5 years ago, one was probably 3 years ago or 4 years ago, whatever it is. But they've been on these drugs for a while, and they were both in remission, doing well. And by remission, I mean that they were in endoscopic remission. That is, they had no symptoms, which is clinical remission. So they were feeling fine, going about their lives, getting married, working in their jobs, doing their things, not having problems with their basic life function because of colitis, and getting the drug, and everything's been good, and we monitor things, and basically they've had their colonoscopies after treatment, and their colon looks normal. It looks normal, and even on biopsies looks normal. So they're in deep histologic remission, meaning when you go in there and get a biopsy of the colon, it basically looks like the guy doesn't have ulcerative colitis. So that's like the holy grail of treatment. And they both obtained it, and things were great. And these guys are not related. It's just two examples that came to mind. It's just really just pissed me off. So basically these two guys were totally in remission, and they both switched insurances at the beginning of the year because of either their employer switched insurances, or they got a new job, or whatever the deal was. They switched from one commercial plan to another. It wasn't like they switched to no insurance, or they were self-pay, or they switched to one of these bare bones insurance companies that doesn't cover anything. They switched to regular insurance plans, commercially available plans that you know the name of. Some of these plans have been in the news lately because they have all kinds of controversy about their CEO, who is no longer with us. But the basic story is that these plans said, no, we don't want to treat this patient with Entyvio anymore because that's not our preferred drug. That's not on our formulary. And basically, what they say is you have to switch the patient to some other drug. And the drug that they preferred is called Skyrizi. And you know what? Skyrizi is a great drug. It's awesome. It works great for colitis. I love it. It's newer than Entyvio, so these patients were already stable on Entyvio. Why would you switch them to another drug that they've never seen before that works totally differently? And although it's a good drug, and I start people on it now all the time, there's no guarantee that my other patients are going to respond to it who've been stable on Entyvio. Like, if it ain't broke, don't fix it. And colitis is not like treating, I don't know, the common cold or treating high blood pressure where you can just switch around the drugs and see what works willy-nilly. Basically what happens with colitis is that these drugs are antibodies. So if you go off these drugs, and there's many different drugs out now for colitis, but there's still only a few classes of drugs. So if you use a drug in one class, say Remicade, and then it doesn't work anymore for whatever reason, maybe the levels dipped too low and your body made antibodies to it, because now the drug itself is an antibody. So if you're exposing yourself to these foreign proteins, these antibodies, and your body is now sensing there's some weirdness going on, it's going to make antibodies to the drug. So your body makes antibodies to Remicade, for example. And Remicade works great until one day you make antibodies to it and it stops working so well. So what you used to do back in the day is you would switch to a different drug, like you would switch to Humira. But the problem is Humira isn't the same class of drugs as Remicade. So very quickly you would make antibodies to Humira too. And then basically the whole class is kind of out the window. And there's ways to like get around it and mess around with different medicines and things and try to preserve it. But for all intents and purposes, you don't want to do that. There's so many other classes of drugs now. So Entyvio is a different class of drug than Remicade. And it doesn't really have a huge immunogenicity, meaning like you don't usually make antibodies to it. But the best way to make antibodies to a drug is to go off of it, because now your body sees little amounts of the drug, and the drug itself is not there to fight for itself and undo the antibodies, which is an amazing thing that happens. And what happens is you make antibodies to the drug. So if we took these guys off Entyvio, like their insurance company wanted, then there's a good chance that the drug would never work again for them. Or there's a small chance that the drug would never work again. But either way, there's a chance that it wouldn't work for them again. And like, they're stable on the drug. What is the purpose of taking them off the drug that has changed their life, that takes months to work, and that they've been on for years and not having any issues with in terms of their blood work or any other parameter that you can measure, and they're happy with? And the reason is because it's not in the insurance company's formulary, which means that they're not making a huge profit off that drug. And it's not in some type of contract they have with a drug manufacturer or whatever it is to basically make a lot of money off that drug. So it's going to not be as profitable to the insurance company to keep the patient on Entyvio, which is the drug he is stable on and doing well on. So they want to switch to this other drug, which I'm sure they somehow profit more off of, for whatever reason, because that's the only imaginable way that I would think that this would make sense. Why would they care what drug the patient's on? These are all very expensive drugs, so they have to have contracts that basically make some of these drugs more affordable to the insurance company to jack up their profits, I guess, is the way it goes. And I'm no policy expert, but I read a little bit about this stuff, so it kind of drives me crazy. So the bottom line is that insurance companies denied Entyvio starting on the first of the year. And of course, you don't find out about this until the patient's until it's after the first of the year, because the insurance changes, then they go to get the infusion, and then they run the insurance. They go, oh, by the way, it's denied. And then you're scrambling to try to get something else to these patients. And they say, we got to use this other drug. This is the one we prefer. So I say, no, we got to use the right drug for the patient. He's not due for the infusion for another 4 weeks. We got some time. Let's get this thing approved. I'll do whatever it takes. And I am writing letters. I'm appealing. This is for both these patients. Multiple different appeals, multiple different letters. What happens is it gets dragged out for so many weeks because you send the appeal in the next day in writing, and then the insurance company sits on it for 2 weeks and does nothing. You call on it. Oh, we don't know. Oh, it's still in process. Oh, call back. Oh, the nurse is reviewing it that works for the insurance company. And who knows what they're doing with it? It's sitting there doing nothing. They probably just throw it out and just deny it again, because that seems to be what happens. And then I get another form that I filled out already 3 times, and I fill it out again, and I send it in. And it's such an epic waste of time. And it takes away from me taking care of other patients, and it takes away from these poor people getting treated properly because they're not getting their drug. And the bottom line is it just delays their care. And now it's late February, and I'm getting phone calls like, hey, I'm starting to get colitis symptoms again. I'm starting to have diarrhea. I'm starting to bleed. And now we have to choose. Do we put the patients on prednisone, which is like a steroid medicine to kind of keep them so they don't flare, which is a pretty toxic treatment for colitis when you're very well stable on a biologic? Or do we fight for a different drug, or do we go with the Skyrizi, which is what the insurance companies want me to give, and start a brand new drug on a person that needs to be induced again, meaning like you have to give multiple doses up front to get them up to a stable level? What do, right? So you call insurance, try to get a status update. They don't get back to you for another week or so. You have to fill out another form. You have to get on a phone call and do a peer-to-peer with an insurance company doctor and beg them to give your patient the drug that they're supposed to get. And what happens? Nothing happens. So now it's like late February, early March, and now the patients are bleeding. They're flaring, they're bleeding, and we have to make a choice. What do we do? Do we give steroids? What do we? It's like a completely unnecessary negative outcome that doesn't need to happen, because they can just continue the drug that they're on, that they're stable on. It doesn't make any sense to me. And what happens is they finally, after 3 appeals or 2 appeals or whatever it is, and 2 months of delaying, both patients are finally approved for Entyvio. But what do we have to do now? We have to re-induce them because their levels are like 0. So now they have to get, instead of just getting the drug every 8 weeks like you normally do it, now they have to get a dose, and then in 2 weeks later, another dose, and then 4 weeks later, another dose. They have to get like an escalated series of doses to get them back up to a steady level so that the drug works. And then the drug takes about 10 to 12 weeks to really fully work. And there's no guarantee it's going to work again in these people. I mean, most likely it will, but there's no guarantee. And they could lose the drug, and then we're forced to switch to some other drug. And what if they have side effects from the other drug? And what if the other drug doesn't work? And then we're switching to some 3rd or 4th line drug. It's just not right. And you see it all the time, and it drives me crazy as a clinician because, and it's not just, I'm just ranting now I'm like fired up, but it's not just me. Obviously, it's everyone who treats patients feels this way, and they may not say it, or they probably do say it, but behind closed doors, everyone who treats patients feels this way. And this is such a problem with healthcare, is that the insurance companies can dictate what a patient can get. They're saying, oh, we don't dictate the care. The care is between you and your doctor. We would never get involved with that. But what's actually happening is they are dictating care, because these drugs are so damn expensive that no normal person can afford these drugs. They are tens of thousands of dollars per dose. So it's like a crazy amount of money. And why are they so expensive? I have no idea. Ask the drug companies, talk to your congressman, like that's going to do anything. For various reasons, it's not going to do anything. But really, they're so expensive. They are cost prohibitive, and you need insurance. And insurance does not pay that much for the drug. They probably get it for pennies on the dollar. But the bottom line is that it's such a racket. And who suffers? The patients suffer. And the doctors suffer, because we're like bashing our heads into a wall, trying to do the right things for our patients. And where do all the angry phone calls come? They come to the doctor's office, because why can't I get my drug? I don't know. Who's the face of that drug? It's the doctor. It's not the insurance bureaucrat or other nameless nurse, insurance reviewer, or whatever that they get angry at. They get angry at their doctor, these patients. And these guys are actually really cool, and they were very understanding of the situation. But how many times do I get yelled at because I can't get a patient something that I want to give them? It's like, it's not me that that can't get you the drug. It's your damn insurance company. And I don't know where this is going with healthcare. And it really is frustrating. And that is the end of my rant, because I could talk about this forever, and I don't know if I have a solution. I don't have a solution. Does anyone have a solution? I don't think so. There's probably a lot of solutions out there, but they have to be implemented in a systems-wide fashion. And I don't think that America is ready for an overhaul of the entire healthcare system, because we can't even get our heads out of our asses for everything else that's going on in America today. Well, that is the end of the episode. This took a dark turn. Started off as a Q&A session, ended up with a crazy bald man ranting in a room to himself. But I hope you enjoyed it, and hopefully you guys see some of the behind-the-scenes stuff that goes on when your doctor is not returning your phone call. It's because he's yelling at an insurance company doctor somewhere in another state that practices OBGYN and not gastroenterology. And that's the state of affairs here. I hope you enjoyed listening to this episode of The Real GI Doc Show. Please subscribe to the show on Apple Podcasts or your favorite podcast player to catch my next episode. If you really want to show your appreciation for the show, take a moment to rate and review the show on Apple Podcasts. It only takes a few seconds and is the best way to get other people to discover the show. If you use social media, you can find me under the handle @RealGIDoc, so feel free to follow, leave a comment, or just say hi. If you have a question about something gastro-related that you'd like me to answer on an upcoming episode, go to realgidoc.com or use the link in the show notes to leave me an audio question.
That's it for this episode of The Real GI Doc Show. Make sure to join Dr. Gandolfo next time to explore another interesting topic in gastrointestinal health. And remember, the views and opinions presented in today's episode are for informational and entertainment purposes only. Nothing discussed in this episode should be considered or used as a substitute for medical advice, diagnosis, or treatment. If you're experiencing a health issue, please consult with a doctor or a medical provider in your area. Thanks again for listening to the show.